Welcome to ResearchMD.com. Another great presentation today. Very, very important topic, congenital adrenal hyperplasia. Before we go into our topic, let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency, and associate professor of medicine at two large medical schools. And again, we've been doing lots and lots of lecture about endocrinology. Our goal is to finish almost all the major topics in endocrinology. We started with the posterior pituitary, we went into anterior pituitary, and then we talked about this adrenal hormone. So today we're going to look at this very special topic for examination purpose. Very, very important because a lot of enzymes involved. It's easy to forget. To make sure, please watch this all over again. Repetition is the key. Okay, so let's start. So what is it like when you talk about congenital adrenal hyperplasia? Let's look at the definition. Okay, we got group of autosomal recessive inherited disorders of steroid biosynthesis caused by enzymatic defect, and you can have adrenal hyperplasia. So what happened is, like, because of these hormones, usually they have a negative feedback going into the hypothalamus, right? Because of the lack of the hormone, the negative feedback is kind of no longer there. So what does it going to do? ACTH start working more and more, right? That can cause like adrenal hyperplasia. That's the main thing we just have to remember, okay? Now, next thing we have to look at these three major hormones. Let's look at the adrenal gland. Where is it situated? On top of the kidney, right? Bilateral. So look at it. You have three parts. You got zona glomerulosa, which produces aldosterone, and then you got zona fasciculata to produce cortisol, and zona reticularis kind of produce DHEA. Okay, so those are the three main hormones produced by adrenal gland. So let's go a little bit deep into find out what's going on. Right? You ready? Let's start with aldosterone. What happened? You got cholesterol that's converted into pregnenolone. And what is the enzyme right here? Cholesterol desmolase. Okay. Now, next step, you got pregnenolone is converted into progesterone. Okay. Let's look at the enzyme involved. 3-beta hydroxysteroid dehydrogenase. Okay. Now, the next step is this progesterone is converted into 11-deoxycorticosterone. Okay, and a very, very important hormone right here, 21 beta hydroxylase is involved right here. And then you got 11-deoxycortisone is converted into corticosterone, and that is the enzyme 11 beta hydroxylase. And then the final step is the corticosterone is converted into aldosterone by aldosterone synthase. So you produce aldosterone. Okay, everybody got that? So that is the number one. You got cholesterol, pregnenolone, progesterone, 11-deoxycorticosterone, corticosterone, aldosterone. Okay, I'm going to go through the enzymes one more time. You got cholesterol desmolase, 3-beta hydroxysteroid dehydrogenase, you got 21-beta hydroxylase, 11-beta hydroxylase, aldosterone synthetase. But two major enzymes I want you to remember is what? 21-beta hydroxylase and 11-beta hydroxylase, okay? Very, very important. So everybody understood about aldosterone. How does it produce? Again, remember, it's in zona glomerulosa, okay? Now, what is our next second hormone? It's the cortisol. Let's look at how does it produce. Again, we start with the cholesterol, okay? And the cholesterol is converted into pregnenolone by this same enzyme, cholesterol desmolase. And then there's another enzyme, 17-alpha hydroxylase, convert this pregnenolone to 70-hydroxy pregnenolone, and the 17-hydroxypregnenolone is converted to 17-hydroxyprogesterone by this enzyme, 3-beta hydroxysteroid dehydrogenase. That's why we put this arrow. Make sure you look at the arrow. So it's kind of effect over here, right? And then we have to look at the 17-hydroxyprogesterone is converted to 11-deoxycortisol. So what is the hormone up here? Again, the major hormone, 21-beta hydroxylase, right? And then 11-deoxycortisol is converted into main hormone, I would say cortisol, in the zona fasciculata. Okay? One more step can happen up here. Cholesterol, pregnenolone, progesterone, and that is also converted to 17-hydroxyprogesterone by 17-hydroxylase, and then 17-hydroxyprogesterone is converted to 11-deoxycortisol by 21-beta hydroxylase. Okay, remember that's a little bit confusing, but make sure, follow the arrow and 21 beta hydroxy works here, and it also works there, and it also works here, 3 places. Okay, so we know how cortisol is produced. Now, what is the last enzyme is DHEA. So we have to look at how does it produce. You got cholesterol, pregnenolone, 17 alpha hydroxylase, 17 hydroxypregnenolone, that is converted into DHE by enzyme 1720 lyase. Okay, that is the main androgen. Remember that. It also, this progesterone is 17-hydroxyprogesterone and androstenedione, which is another androgen. Okay? So remember those kind of things. And that is also converted to testosterone. So that's the normal. So now look at what happens, what is in the abnormal thing. We have 3 main enzymes completely gone. Okay? Which one are they? 21 beta hydroxylase, my friend, and 11 beta hydroxylase, and then 17 alpha hydroxylase. Those are the 3 major anomalies in the congenital adrenal hyperplasia. You need to know in and out how this thing works before we can go into the detail. Okay, so let's look at what happens. I'm going to stand up here, and again, we just kind of put it up here. I'm going to circle. We'll circle right here our major hormone deficiency, 21 beta hydroxylase. Okay, so we got, let's look at it over here, 21 beta hydroxylase. Let's see like what happened to 21 beta hydroxylase. So this is blocked all this way, 21 beta hydroxylase. So are you going to have aldosterone? No. Are you going to have cortisol? No. So because this part is blocked from here, because progesterone is not converted into 11-deoxycortisone or corticosterone and aldosterone. So aldosterone is completely gone. Cortisol is also gone because this enzyme is working here and here. Everybody got that? Okay, so very important. So what happens when you don't have aldosterone? What's going to happen to your blood pressure? Is going to go low. Okay, at the same time, what happened to in the female? You got excess genotype. Okay, so we're blocking only here. So what's going to happen to this part? This part is continues to produce like more because you got hyperplasia. SUTH is working overtime, right? So this is kind of converted into DHEA. Remember that. Only this part is the one is kind of blocked. 21 beta hydroxylase is gone because all this enzyme from here is not getting produced. Okay, so let's look at female. What happens when you have too much androgen in female? Right? All the organs go crazy. You got clitoromegaly. You got female pseudohermaphroditism. Male external genitalia with the uterus and ovaries could be the future. And then you can have precocious puberty, virilization, irregular menses, infertility. All kind of like because of the excessive androgen they don't need. Now, what happened to the male XY genotype? Usually it doesn't affect that much because they're going to be, when at birth, they're going to have male external genitalia at birth. Only problem, they can have precocious puberty. Okay? Remember that. Puberty is going to be early in that group. So everybody got that? So again, it's very, very complicated. So I'm going to go over it again. So here, the enzyme 21 beta hydroxylase is blocked. Okay, so what's going to happen? This part, all this part is like completely gone. You're not making aldosterone. If you don't, because aldosterone is going to decrease. If you don't have aldosterone, your blood pressure is going to go down, right? So we have to know that. And cortisol also is important to keep the blood volume. So your blood pressure is going to go down. You're going to have all of this down, but this is going to work like extra overtime right here. Right? So you're going to have a lot of androgen, and just look at the difference in the male and the female. Female will go crazy, clitoromegaly, all kind of problems, female. Male only problem is precocious puberty. Okay? Now, let's look at the second enzyme right here. 11 beta hydroxylase. Now, what does it block again? It blocks from here, down here, right? Only 2. This one is blocked, so you're not going to have aldosterone. You're not going to have cortisol. So what is our thing? So let's ask, why is the blood pressure still remains high? You expect is going to be low. The reason for that, my friend, this 11-deoxycorticosterone have some kind of mineralocorticoid activity to keep the blood pressure high. Okay? Because this part is going to go high because of the this thing is going to produce a lot of 11-deoxycorticosterone. When you have lots and lots of deoxycorticosterone, that's going to drive your blood pressure high, because it does have some mineralocorticoid activity. Remember that, very important. Okay. Now, so what happens? So 11-beta hydroxylase high, but all the other thing is going to remain the same, because this part is continuing to produce more DHEA. Okay, our third important enzyme, what is that? 17 alpha hydroxylase. Okay, and what does it do? Now, this, cholesterol, pregnenolone, use 17 hydroxylase, convert it into DHEA. If it is not there, DHEA is going to be there? No. And then here, progesterone, you need 17 alpha hydroxylase convert to androstenedione. These are both androgen. So is it going to be there? No, because this is blocked, this both two blocked, so DHEA is not going to be there, androstenedione is going to be there. Okay. Now what happened to this part? What happened to aldosterone? Aldosterone is going to be continuously produced, right? Because ACTH is working what? Overtime, right? Because there's nothing happening up here. This aldosterone continues to produce. So what's happening to your blood pressure is going to go high. Now, so if there is no androgen over here, so what's going to happen? Female genitalia, nothing is going to affect them, right? The only thing is going to see delayed puberty. But look at what happened to the male. It's like a complete mess right there, because they need androgen, right, to produce all these organs, to development and all that. So all of them, they kind of have like more female characteristic, male pseudohermaphroditism, female external genitalia, blind enzyme vagina, intraabdominal testis, but delayed puberty. It's like a complete mess for a male. Okay? Remember, this 21-beta hydroxylase and 11-beta hydroxylase, you got too much androgen, so it's more on the female. Here, less androgen, so male is going to suffer. Okay? So remember that. So now we let's look at this. Another, we talk about, remember, 3 enzymes we talked about: 21-beta hydroxylase, 11-beta hydroxylase, and 17 alpha hydroxylase. Okay? Now, all 3, what is the most important hormone? 21-beta hydroxylase. Okay? On the 21-beta hydroxylase, there's 2 different types we need to know. One is like classic, another one is non-classic. Okay, so what happened? Let's look at the difference between classic and non-classic. You have severe up here, this is mild, this cannot be detected. This can be detected, the classic one in the neonatal screening, but this is not detected neonatal screening. Okay, and then you got less common prevalence, this is more common. So mild is more common, thank goodness. And then Inuit and Alaska Natives is more common, that's like Arctic people. And this Ashkenazi Jews and white people is kind of very common in that field. Okay, and then early onset, the neonatal period or early infancy, this is late childhood and adolescent in the adult could have present in the mild. And then you got, like, when you look at this classic, there's 2 types we need to know. Main thing, there's some salt wasting 75% of the time, which you usually have, like, failure to thrive, then you can have hyponatremia, you can have like hyperkalemia, inappropriate natriuresis. Okay, remember, you can have hyponatremia, hyperkalemia, inappropriate natriuresis. Okay, so this is in the no salt wasting, you will not find any of that. Luckily, 25% we don't have it. This is salt wasting is presenting at early in the child period, like 7 to 14 days of birth. The other one like 2 to 4 years. Okay, and then female ambiguous genitalia in the salt wasting, and the female also ambiguous genitalia. In the male in the no salt wasting, you can have like precocious puberty. Okay, and let's now, we finished it, but we have to treat it, right? Let's look at the treatment. What are the treatments? Very, very important, right? You got low dose hydrocortisone in children, okay? Low dose. Reason, after puberty, you can use dexamethasone or prednisone, because if you give, early in child, the bone growth will be affected. There's going to be stunted growth. So don't use these 2 drugs early. Just use like low dose steroid or low dose hydrocortisone in children. That is, in the treatment, but in the adult, you can use dexamethasone or prednisone. And then 9-fluorocortisone in the salt wasting. Remember, we talked about salt wasting. Use 9-fluorocortisone. You can use like sodium chloride tablet, because hypernatremia is very common in these people. And surgery in the female ambiguous genitalia in the female. Obviously, you can do like surgery to fix that. Okay. Now, let's go back and look at the beautiful whiteboard again. Just kind of summarize what we learned so far. Okay, let's go. So you got like three, you have to know like how these enzymes are produced, three major enzymes, aldosterone, cortisol, and DHEA. Okay, so when we talk about, you got three, you got cholesterol, pregnenolone, progesterone, 11-deoxycorticosterone, corticosterone, aldosterone. Let's look at only two enzymes, major enzymes, 21 beta hydroxylase and 11 beta hydroxylase. Okay, and then, so what happened? Let's look at the first enzyme, 21 beta hydroxylase. I'm going to repeat it again because it's very, very important. So what happens is over here, when you have 21 beta hydroxylase blocked, right? So it's like a blockage right here. So this part is completely gone. So we want to have corticosterone. You don't have aldosterone. You cannot have a cortisol. Only thing, what happens over here? This thing is going to continue to pump DHEA because ACTH is working over time. So what's going to happen? When you don't have aldosterone, your blood pressure is going to be low. When you have too much DHEA, female's organs is going to go crazy. Sexual organs, male, nothing much, right? So next hormone, we're going to talk about 11 beta hydroxylase. Okay, it's blocked only from here downwards. So again, aldosterone is cortisol is affected, but there's some, this 11-deoxycorticosteroid has some kind of mineralocorticoid activity, so the blood pressure remains high. Okay, very important to know that. But what happened over here, DHEA and androstenedione is going to go crazy because this part is not blocked. It continue to overtime, right? So that's going to have the female is going to go crazy, female organ. Now, next important hormone is like 17 alpha hydroxylase is blocking right here and here, so DHEA is not produced, androstenedione, androgen. Who needs the androgen most? The male. So male organs is going to go completely crazy right here. So male people, okay? So remember, what happened to the blood pressure? Because blood pressure is going to get affected, it's going to go high because this part is not working, but this part continue to work over time, so you're going to have a high aldosterone, so blood pressure is going to be high. Okay, got it. Now, you got 21 beta hydroxylase. Remember, there's two types. There's classic and non-classic. And non-classic is kind of like mild, like later onset. Main thing you need to know is salt wasting and non-salt wasting. Two parts in the classic. Okay, so what happened is the salt wasting, 75% can have like salt wasting. Failure to thrive is a major thing. Hyponatremia, hyperkalemia, incomplete natriuresis is common, my friend. Always remember the salt wasting, okay? Now, let's look at the treatment, the final treatment, low dose hydrocortisone in children because, okay, you have to use low dose because otherwise your bone growth, all the bone growth is going to be affected. So, after puberty, you can do high dose steroids like dexamethasone, prednisone because, child has grown up already, bone growth is not going to be stunted. Now, how do you treat salt wasting? You got 9-fluorocortisone and give some sodium tablet because you got like hyponatremia in this group, and the surgery finally because all these female organs have gone crazy, so you need surgery to fix it. So again, my friends, very, very important topic. Please, I wanted you to review this at least 2 to 3 times before you take a test, okay? You can expect at least 4 or 5 questions. And it's very simple as long as you understand how these hormones work, okay? Study hard. Thank you so much for watching.